We have to start on time. So our session is translation of Madam. She's asking for the link in Hall A. I'm in Hall A. Dr. Fazana is asking.
We've sent it to her.
You send it to her, no, ma'am. Okay. Just in case I lost it. Okay. So our topic here is from journal to bedside knowledge translation. So just a minute, madam. 1 minute. Sending to Dr. Fazana again. Yeah. So my chairpersons today are Dr. Fazana and Dr. Rajeshri, madam. Dr. Fazana, madam, is CEO and president, and she's a PhD fellow of global health. She's presently affiliated with the Faizuddin Khan Research Foundation, Dhaka, Bangladesh, and she has more than 25 years of experience in palliative care. So her areas of interest are palliative care in humanitarian context and palliative care at primary health care levels. Are you able to see my screen? Madam, are you able to see my screen? Faculty in palliative care, presently affiliated with the Amrita Institute of Medical Sciences, Kochi, Kerala, and IPM, Thrissur, Kerala. Institute of Palliative Care, Thrissur, Kerala. She has 22 years of experience, and her areas of interest are palliative care for older people, end-of-life care, mental health care for palliative care patients. So I would request Dr. Rajeshri, madam, is she available now? I think.
Yes, sir.
Institute of Palliative Care, Thrissur, Kerala. She has 22 years of experience, and her areas of interest are palliative care for older. Yeah. Dr. Fazana, madam, you can introduce Dr. Audit, madam, and the session can be started. Dr. Fazana Khan, can you please introduce Dr. Audit, and we can start the session. The session can be started.
Okay. Thank you. Am I audible?
Yes, ma'am.
Thank you. So let me introduce Dr. Audit. I'm sure she is very known to all over India.
Dr. Fazana Khan, can you please introduce Dr. Audit, and we can start this session.
Okay. Thank you. Am I audible?
Yes, ma'am.
So Dr. Audit is an associate professor, palliative medicine specialist, and her present affiliation is with the University of Melbourne. And she has 30 years of experience in palliative medicine, and she is interested in patient and healthcare provider relationship, and also international development of palliative care. Her major achievements are she has got PhD in palliative care in 2020, and she has over 50 publications and 7 book chapters. And she is the founder and chair of APLI, and she is the supervisor and mentor of many palliative medicine advanced training, as I have already told you. So with my deepest respect to herself and her achievements, may I welcome Dr. Audit on board. Thank you. She is the founder and chair of APLI, and she is the supervisor and mentor.
Can we start with the recording of Dr. Audit?
Good evening. It's great to be part of the conference, even if only virtually. It would have been wonderful to be in Jaipur. It's such a beautiful city, but we look forward to that another time. So I've chosen an article that reviews the impact of relationship-centred care in the health literature. Before discussing the article, I'd like to give some background as to why I chose this topic and these articles. So in my study on the way that doctors in Australia and India try to respond to suffering in their patients at the end of life, the relational dimension of care was clearly identified in the interviews as being of critical importance. I found this term dialogical encounter to be helpful to describe a meaningful or the meaningful connection that may arise, that may take place between the doctor and the patient, and that it was through this human-to-human meeting between two subjects, the patient and the practitioner, both in their humanity, that there may be the potential for healing, for a movement towards a new experience of integrity, and not only for the patient, but also potentially for the doctor. Not only do we meet as patient and practitioner, two individuals, but we bring our full subjectivity to the encounter, to this space shown here in the arrow, this intersubjective space between the two, the person who here is dying or bereaved and the care provider. Papadatu is a paediatric physician in Greece who has published on this concept in healthcare. So the world, or the subjectivity of the patient and the subjectivity of the care provider meet, both bringing their larger worlds to that encounter. For the patient, they bring their family, their significant others. For the care provider, they bring their team and their supervisors and those for whom they are responsible for the care they carry out. And this all takes place within an organisational context, within a community and within a social and a cultural world. So all these influences impact on the encounter between health provider and patient. What is relationship-centred care? It's a framework for conceptualising healthcare which recognises that the nature and quality of relationships in healthcare influence the process and outcomes of that healthcare. The term was defined by a task force in 1994, the Pew-Fetzer Task Force, and this group recommended ways to integrate this concept, this framework, into healthcare at the organisational level, at the educational level for healthcare providers, and also the clinical level, clinical practice. In essence, the essential principles of relationship-centred care are the centrality of relationships and the importance of personhood in healthcare. So getting to the article that I'd like to review, it's by Soklaridis and colleagues, was published in 2016 in the Patient Experience Journal, and it's a 20-year scoping review of this concept of relationship-centred care. In addition, I'm going to mention two other articles briefly, both of which speak to this importance of relationship and intersubjectivity in clinical care. So, as I mentioned, this article is a scoping review of the concept and practice of relationship-centred care to assess its penetration and impact on healthcare delivery. The research question was, what is known from the existing literature about relationship-centred care in health? The authors included all publications between 1994 and June 2014, including the grey literature, online publications, websites, commentaries and opinion pieces. They included articles found by hand searching and also recommended by other contacted authors. And they searched all the major databases such as Medline, CINAHL, Embase, PsycInfo, and evidence-based medicine datasets. The search terms that they used are shown here: relationship-centered care, health, treatment, therapy, counselling, healthcare, outcomes, practice, and models. The titles and abstracts were reviewed by the first author, and then they underwent, as a research group, they underwent a calibration exercise in which 3 of the authors independently screened 5% of the articles to come to some consensus on the inclusion and exclusion criteria. Then all the articles were again reviewed by the first author for eligibility, with a final group of 69 articles selected. And these articles were then divided among the 3 authors for data extraction using 2 forms, one for the more theoretical or conceptual articles and one for the research articles. Key dimensions and thematic findings were identified and synthesized into an overview of relationship-centered care in the health literature. As mentioned, 69 articles were selected. 54% of these were theoretical or conceptual and 25% were research. There were 7 books and 7 review articles also identified. They noted that there were some publication peaks in the late 1990s, 2004 and 2006, and these seem to flow from additional publications by the Pew Fetzer Task Force group. The fields from which the articles came were geriatric medicine, healthcare systems, and some from medical education, interprofessional education, and health professional education. Mostly the literature comes from the USA, and they identified also a number of online sites. For me, it was interesting that there were no articles from palliative medicine, given how central these concepts of patient and family and team are to our palliative care practice. 6 main themes were identified in the thematic analysis of the literature. First was the definitional discussions in the literature of what relationship-centered care is. Secondly, the theoretical concepts which underpinned relationship-centered care. Then the relational themes themselves. And then from one of those themes, the practitioner organisational dimension, they identified 3 sub-themes. Then the practice of relationship-centered care itself and the importance, impact and outcomes of relationship-centered care. I'll go through these one by one in more detail. So the first theme refers to the literature discussing what relationship-centered care actually is. And the Pew Fetzer Task Force definition was the most often referred to in the literature. That group identified 3 relational dimensions of relationship-centered care: the patient and practitioner, community and practitioner, and the practitioner with other practitioners. In 2006, another author, Beach and colleagues, added the clinical relationship with self as practitioner as another dimension. And other authors such as Suckman, Marble, Safran et al. Added organisational dimensions to the definition and scope of relationship-centred care. Another feature of this literature, this definitional literature, was to distinguish relationship-centred care from person-centred care. And here authors talked about how relationship-centred care focuses on how patients and health professionals relate to each other and views those relationships as therapeutic and in fact as the medium of care. It talks about valuing the patient and health professionals as active participants together in care. It focuses on health professionals being self-aware and present for themselves and for others, this relationship with self component. And also relationship-centered care recognises that interactions between patients and care providers influence the course and outcomes of care. And the paper that I'll talk about later by Agarwal illustrates that nicely. The second theme dealt with the theoretical constructs which underpin relationship-centered care. Three approaches were identified, three theoretical approaches coming from sociology, social psychology and psychiatry, with each of those fields having several theoretical concepts referred to in the literature in relation to relationship-centered care, as shown in this table. Relational themes were the practitioner in relationship to the patient, the practitioner to themselves, to other practitioners, to the community, and to the organisation. And within the organisational theme, there were three sub-themes. The first one was the practitioner and education. So here, this refers to the literature which talked about incorporating relationship-centred care into the health professionals' education as a central competency, and to develop a national curriculum framework that supports human relationships, and to develop performance metrics to measure the progress on a relational approach to education and practice. The second sub-theme was the practitioner and profession. And this is interesting in that there was a recognition that a move beyond a cure focus to a more care and quality of life focus resulted in an improvement in the morale of health professionals who care for patients, particularly patients who are elderly or have chronic or progressive illness. And likewise, for us in palliative care, we know this to be a component of our practice also. And finally, practitioner to practice, sub-theme within this organisational theme, looks at how the physical space and the interpersonal interactions in the clinical practice environment and the organisational structures might either enhance or detract from positive relational dynamics, making them positive or not positive. There was an article published by one of the authors referred to in this review, Frankel and colleagues, looking at the impact of how, this was published after the period of this scoping review, how physicians' trust in one another impacts on their practice and the outcome of their patient care. The practice of relationship-centred care was the next theme. Here, the literature refers to ways in which to create organisational environments that model relationship-centred care, how to establish practice settings that focus more on patient and family support and engagement in care planning, and how to emphasise basing health providers' education on relationship-centred care. Strategies for increasing relationship-centred care capacity in education include using narrative and reflective teaching, allowing more time for reflection within the curriculum, to use non-competitive and more formative assessments, and to use journal writing and peer mentoring as strategies. The types of competencies which lend themselves to relationship-centred care practice include learning to be better listeners, be less self-conscious, learning to ask for help, to accept one's limitations, to develop appropriate relationships with patients, being collegial, dealing with one's feelings, and being comfortable with the unknown. The sixth theme looked at the impact, importance, and outcomes in the literature on relationship-centred care. And there is a long list of positive outcomes. For example, patients were said to be more likely to have healthy behaviours, improved satisfaction, and also improved health professional satisfaction, higher medication adherence, better physical and mental health, fewer healthcare visits, less litigation. And one would wonder if there would be less anger and conflict within the system. It also is said to improve cohesion in the workplace with a less hierarchical and more partnership model of working relationships, and to lower patient mortality, and also to reduce the disparities in healthcare which are based on ethnicity and race, because of a greater degree of self-awareness and self-reflection by practitioners, and better recognition of our biases. The review also identified 3 themes for future research, 2 of which looked at reforming health professionals' education approaches and reforming the healthcare system itself, and the other which looked at the need for more evaluation of relationship-centred care practices in clinical and education areas, such as studying the interactions between a health professional and patient in the clinic, and studying a health professional's capacity for self-awareness, for example. Limits to the review included the gaps in the relational dimensions of the practitioner-patient with respect to family and caregiver role, and the practitioner and the community. These gaps were largely attributed to a lack of publications that have looked at those areas. The review also did not include other relational theories coming from psychoanalytic or psychotherapy fields. It only included English language studies, and there was no attempt to evaluate the quality of the included studies. In the remaining minute or two, I'd like to talk about these 2 further articles that I think illustrate these concepts of intersubjectivity and the relational dimensions of care. This article by Agarwal is from the transcultural psychiatry literature. He discusses this concept of a hybridized identity and also of intersubjectivity in the clinical encounter. He shows the value of moving from a unidimensional label, such as Indian or Indian American, to an understanding of the hybrid nature of our identities. The article is, in essence, a case review and discussion. The author, doctor, cared for Mr. Raju in an inpatient psychiatric unit. The patient was admitted for treatment of depression and risk of self-harm. And the patient was initially seen by 7 other psychiatrists before the author was asked to take on his care. And the author was in part assigned this patient because it was assumed they shared a cultural background. And the previous psychiatrist had noted that the patient was Indian or Indian American. But in fact, with this author, the patient who explored this patient's cultural identity in a more formal way, the patient actually described himself as a brown man in a white man's world. And the author states, as a man, an Indian, an American, a veteran, a health professional, among other subjectivities, Mr. Raju exemplifies the hybridized identity. He writes, his case demonstrates his intersubjective responses to clinicians. His cultural identity shifted until he realized that the group to which he most belonged and with which he experienced his greatest disappointment was the military. Despite our similarities, I understood his suffering only distantly, since his transition between both countries and military experience introduced significant differences. The cultural formulation elicited migration and military history as major factors of identity. The author also noted the importance of the intersubjective in the interaction between clinician and patient. He says the ways in which the patient and clinician view each other may influence the direction of an interview and the data elicited. Predetermined designations of clinicians may affect such dimensions as the assessment of mood, affect, thought process, and content, insight, and judgment in the mental status examination. So in essence, we bring our preconceptions to the evaluation and so need to be self-aware and reflective in our practice. And the second paper is one of a series of papers from the journal Bioethics in 2019. This one was a grounded theory and interpretive phenomenological analysis of 248 interviews with 62 patients, family caregivers, and professionals, asking about their perception of self-perceived burden and how that influenced their wish to die. It was another clear expression of this relational world, and in a review of this concept, which was one of the other articles in the series, the phenomenology of this as arising from within the intersubjective realm was highlighted, and therefore again the need to develop our capacity as health professionals to enter this relational intersubjective space with a high degree of self-awareness, self-examination and reflection of our own projections and perceptions. Thank you very much, and I'll finish up here.
Thank you very much, Dr. Audit, madam. So, yeah, I would request Dr. Rajeshri madam to introduce Dr. Naveen Salins sir and Dr. Anil Paleri sir one by one, and we will play the videos back to back. So please Rajeshri madam, can you introduce Naveen Salins sir and followed by Anil Paleri sir immediately? Thank you, madam.
Good evening, and I am honored to introduce Dr. Naveen Salins, who is currently heading, and he is a professor of Department of Palliative Medicine and Supportive Care in Kasturba Medical College, Manipal. And he is the alumnus of the same institution for his undergraduation and also for his post-graduation in internal medicine. In addition to that, he has FRCP from Glasgow and London and PhD and clinical fellowship in palliative medicine to his credits. And he is the
Rajeshri, you're mute.
I mean, like, should I start from the beginning?
No, the last sentence.
No, madam, you can introduce Dr. Paleri.
And I am pleased to invite Dr. Naveen Salins to present the journal to bedside, and his topic is using the theory of change framework to enhance ICU palliative care engagement in India. Over to Naveen.
Hi, everyone. Welcome to the session on Journal to Clinical Practice. On this thematic note, I would be talking about an unique article which I found it interesting and applicable, that is using theory of change framework to enhance ICU palliative care engagement in India. So theory of change framework is a methodology paper. And I have used that methodology paper to enhance ICU palliative care engagement in India. And let's see how it all happened. So we always think about bringing a complex change. So what is a change versus a complex change? So a complex change is one where the change is required at multiple levels. It could be at an individual level, it could be at an organizational level, it could be in a group of people within a team, or it could be at the level of policy. So here the change is not just coming at one level, it is coming at multiple levels. And this change has to be synchronous. It's not that the policy has happened and the individuals have decided to change later on. So all things are happening in a very synchronous manner, and this change has to be sustained. So enhancing palliative care in an intensive care unit needed a complex change. So we needed a framework to bring about the complex change. So that's why we used theory of change as a framework to bring about complex change. So before we go into theory of change per se, we need to a little bit dwell upon what is a complex change. So complex change requires many parameters that comes together, or many aspects that comes together. So you need a vision, you need adequate skill mix, you need incentive for change, you need to have adequate resources that could bring about the change. And most important, you need to have an action plan to bring about the change. Everything that comes together, the vision, the skill, the incentives, the resources, and the action plan could bring about the complex change. If something is missing, then you could be either, you can have confusion, anxiety, or there could be resistance for the change, or people bringing about the change may be frustrated, or the change may not take off itself, what we call as a false starts. So we need to understand what are the ingredients that bring about this complex change. So as I started to mention, the thematic area of this presentation is from journal to clinical practice. And this paper, Theory of Change, a theory-driven approach to enhance Medical Research Council's framework for complex intervention, is the journal paper that I have chosen to bring about this change, or bring about the change that what we had to do in the ICUs. And interestingly, this paper has come from India, it's from Goa. So we would focus on two things, the complex change and complex intervention. So Medical Research Council proposed a framework for complex intervention. The theory of change is a framework for complex change. Now let's see how to marry it together, the complex change and complex intervention, and how it could be applicable in the clinical practice. So the overview of my presentation is, what is theory of change approach? So we'll talk about a very broad framework of what is theory of change approach. And secondly, we will talk about how have we used theory of change approach to enhance ICU palliative care engagement. So this would be the overview of the presentation. So coming to the first one, that is, what is theory of change? So before we go to what is theory of change, we need to be familiar with three terms: change, transformation, and emancipation. So what is change? Change is a response to an external influence, where it involves modifying our day-to-day action or work that we do to get a desired result. So which is a very important starting point. So change leads to transformation. So transformation is not just the modification of day-to-day work. It is the change in the core beliefs, or the modification in the core beliefs and the behaviors of the stakeholders involved in the change. So we are not just changing the work pattern, but we are also changing the beliefs and behavior, and which would have a much longer impact than the change in the work pattern to get the desired result. And emancipation is the outcome that you get. So it is that any effort that brings about equity, freedom, or liberation for a disenfranchised group. So if you look at here in our subset, we have the patients who are admitted in intensive care unit, and their caregivers are probably intimidated or overwhelmed and probably form a disenfranchised group. And how do we bring that equity for them, the freedom from them, or the liberation from them? By integrating palliative care is what we are going to look at. So we have change, transformation. So change leading to transformation, transformation leading to emancipation. So this looks a very complicated diagram which I have drawn from the MRC UK complex intervention research cycle. So we have the research cycle of the recommended by the Medical Research Council. So the MRC has proposed an algorithm or a framework to conduct research that involves complex intervention. So what is that framework? You develop a complex intervention. So based on what is already known, what needs to be known, and how to adapt an existing evidence. You assess feasibility of conducting that study using that complex intervention. You evaluate the outcomes of complex intervention, and the outcomes you disseminate and implement it in your practice. So this is the broad framework which is given by the MRC. But this framework had some shortcomings. So what were the shortcomings of the MRC UK complex intervention research cycle? One, although it provided a framework, it lacked guidance on how to incorporate change. So it just gave a framework in terms of developing intervention, knowing feasibility, knowing the outcomes of intervention, and dissemination implementation. But how exactly to bring about this change while designing an intervention or evaluating an outcome was missing in the MRC cycle. The second thing is, what are the mechanisms that bring about the change was also missing. Unless we understand what are the mechanisms that is bringing out the change, we can't just talk about a change. So this again was a missing aspect. So what are the deeper layers or the underlying mechanism? And also it failed to bring in the context. The complex interventions are used in a context. It may be clinical context or in a research setting. So that context has a huge influence or interacts with the complex intervention. Now, how these interventions are interacting with the context has not been accounted for. So these were the three shortcomings that were there, for which we needed to bring about needed to have the theory of change coming in. So it's very important to understand, to know what does theory of change represent. So theory of change represent how and why an initiative or intervention works. So we all know in a trial setting, we know that an intervention would lead to a certain outcome or has a certain benefit or not a benefit. But what is making that outcome happen, or what is causing that benefit, or what is causing an undesired effect, is always not known in an intervention trial. So theory of change is to go deeper into the system, to understand the deeper layers of reality. If you look at this diagram that I have given, you have a man looking at a tree, but his vision or his view of the tree is blocked by a wall. So he probably looks only at the leaves or some of the branches. But the tree has a trunk, but more importantly, the roots. Everything is important for the tree to exist. So it's not just what you see. What you see is what is empiric. That is, you do a study and you get an outcome. But what is leading to that outcome? That's the trunk and the root, what we call it as the deeper layers of reality. So theory of change is to understand what are those deeper layers of reality, which is helping something to work. So it has to be measured. Again, these deeper layers of reality is not imagination. It also has to be empirically tested. And there are indicators to measure that also. So if you look at the framework, its theory of change is always in the reverse direction. You always determine what is that impact that you want to achieve. What is the long-term outcome you want to achieve? What are the preconditions that are needed for this outcome to be achieved? What are the assumptions? I'm going to come to each of these terms. And you draw the theory of change map for a thing that you want to bring about the change. So I'll show you how we have drawn the theory of change map for ICU palliative care intervention. So how to use theory of change framework? It is a participatory one. So as a palliative care person, I can't tell how the change has to happen or how palliative care should integrate within ICU or how our integration has to be enhanced. It has to be a co-created knowledge. So you identify who are all the stakeholders who are important to be part of this process. And you use certain methods, like you engage stakeholders using workshops, interviews, and I said it's in the reverse order. So you identify the impact. What is that ultimately that you would like to achieve? And you go back from there. So that's the most important difference between theory of change and other frameworks that we are using. So these are certain important terms that people should know about. Is what does it impact means? Impact is the real world change that you would like to bring about. The long-term outcome is the final outcome of the intervention. There's something called the ceiling of accountability, where you measure certain indicators which will determine what the outcomes are, and certain indicators cannot be measured or are independent of the outcome. An indicator is the one that you measure. Precondition are the outcomes, basically. The things that don't exist but need to exist in order to lead to an outcome. So what is not there, you want to bring about. That's the desired result of intervention. And assumption is an external condition that's outside the project, which needs to exist, like a policy, or you need an administrative support for an outcome to be achieved. So coming to how we applied this in our project. So this was through the GCRF UK grant, and it was conducted using 3 organizations: Lancaster University from UK, Manipal, this KMC Manipal, and Karunashraya Bangalore Hospice Trust. We had 13 intensivists from 5 ICs across India coming as stakeholders, and we had 3 facilitators from UK and 3 from India. And we conducted 5 workshops as part of theory of change workshop. The first workshop was on impact or the ultimate goal. The second workshop was on long-term outcomes. The third workshop was on preconditions and assumptions. Fourth was on intervention. And the fifth was how we are going to use the entire thing that we learned into our clinical practice, which also include drawing the theory of change map. So this was the overview of the project that we conducted. This is an example of a sample workshop. This was the workshop on intervention. And each workshop was 2 hours long, conducted virtually. And each workshop had an agenda on which we worked. So the first, I'm just giving an examples. So we worked on in the workshop 1, we worked on what is the long-term outcome that we want. So all the stakeholders agreed that the good death was the long-term outcome. So what is the meaning of good death? This was all taken, some were taken from the previous literature, some were taken from the workshop. So we systematically documented all of them, the outcomes of each workshop. So we identified, and even from the previous literature, what were important and what was less important. Similarly, we worked on interventions. So what are the interventions that we need to develop? So we looked at what is available from the literature and what are the things that were generated from the views of the stakeholders in terms of what should be the intervention that should ultimately lead to the final outcome. So this is how the theory of change map was evolving. So at one point we developed what are the things that makes good death, like for example, fewer discharges against medical advice, because this is very contextual for ICUs, like reduction in inappropriate ICU admission, reduced deaths in ICU, reduced cost, all these things. So precondition is what are the things that needs to change to achieve that. So changes in perception about the law, early palliative care conversation, because preconditions are something that was not there, which we want to make. And similarly, interventions and assumptions in terms of, again, changing the perception of lack of time, perceptions illegal, how policies or administration can bring about these changes. And if you see here, over a period of time, the theory of change map started to evolve. If I had longer time, I probably would have explained everything to you. And this was the final theory of map that we developed for the ICU palliative care engagement. And if you see here, on one end, there is the final outcome after the ceiling of accountability, the better end of life care and good death. The one in the green box is the long-term outcomes: reduced ICU death, reduced discharge against medical advice, reduced inappropriate admissions to ICU, increased specialist palliative care referral, improving satisfaction. Then we came about with almost 12 preconditions. And each preconditions, and if you see here, I1 to I11 are the interventions. So to achieve these 12 preconditions or the things, we had interventions. So you can see the list of interventions. And in the red box that you see are the overarching assumptions. There are certain that some of these could be changed, or some of them, if this probably overarching assumptions are probably difficult to change, but if they are changed, that will be very helpful. So that's how we evolved the theory of map. And this is how it helps. So I started with the MRC research cycle. And here I'm telling how the theory of change strengthens each aspect of the MRC research cycle. So it starts to complement. So there are definitely good points in the MRC research cycle, and there are good points in theory of change. The art is to combine them together for a better outcome. Thank you very much for this opportunity, and I'm happy to take if there are any questions.
Yeah, thank you very much, sir, for the presentation. We'll postpone the questions later. Rashmi ma'am, can you introduce Dr. Anil Palari sir to the audience, and we will start his session.
Okay. Anil Palari, my senior colleague at Institute of Palliative Medicine in Calicut. I am pleased to introduce him as one of the speakers for this excellent session. He's currently leading as the clinical director of palliative care services in Calicut City, which is a consortium of NGOs providing excellent home-based care for the palliative care patients. In addition to that, he is the scientific reviewer of Indian Journal of Palliative Care and is a former director of Institute of Palliative Medicine, which is a WHO collaborating center for community participation in long-term care and palliative care. And he also was the past honorary secretary of IAPC for 2 terms and is a founding trustee of World Hospice and Palliative Care Alliance. And today, from Journal to Bedside, his topic is use of steroids in advanced cancer. It's a very relevant topic for the day-to-day palliative care practice. So I am pleased to invite you, Dr. Anil Palari, to enrich us with your expertise. Over to Anil.
Hello, everyone. Good evening. The title of the session is From the Journal to the Bedside, Knowledge Translation. And I will be discussing an article, a review article published last year in Palliative Medicine on the use of corticosteroids in advanced cancer. Next slide, please. We use corticosteroids in palliative care often. In fact, it's one of the most commonly used medicines in palliative medicine. And we use it for various reasons, some non-indications, but sometimes we also use it for not so sure indications. Like when the symptom, a certain symptom is not responding to the known protocols or known treatments, we tend to use steroids, hoping that it is somehow going to control the symptom, something like a magic bullet. And we do all this all the while fully knowing that there are many side effects, which are well documented and well known. Next one. This is the article I'll be discussing tonight. It's a review article published in 2021 in Palliative Medicine. Practice review, evidence-based quality use of corticosteroids in palliative care of patients with advanced cancer. Authored by Janet Hardy, Alison Haywood, Christy Rickett, Libby Salo, and Philip Good. Next one. Looking at the methodology, this is a state-of-the-art review. When you say state-of-the-art review, it considers mainly the most current research or present state of scientific development in a given area or topic. So it's getting information from the current research. And they look for reviews of reviews, RCTs, control trials, all these things, and are written in English. And for them, short term means less than 2 weeks, long term means more than 4 weeks. And they have put the recommendations with D3 method and also varying strength of recommendation. D3 method means the do's, don'ts, and don'ts. Do's mean there is good evidence for its use in palliative care and there is a better risk-benefit ratio. Don'ts means there is evidence for lack of efficacy and also the risk-benefit ratio is unfavorable. That means there can be more harm than the benefit. Don't know means there is limited evidence or no evidence in a context in advanced cancer, but there is evidence in context other than cancer. But we don't know how that translates that knowledge in advanced cancer, in the context of advanced cancer. The strength of recommendation comes as strong, moderate, and tentative. Strong means there's a large and consistent body of high quality evidence like RCTs, systematic reviews, or meta-analysis, etc. Moderate means at least one control study supporting on consistent findings from the cohort studies and consensus statements. Tentative means there is little empirical evidence, but there is consensus among experts and authors on that particular recommendation. Next slide, please. These are mentioned by the authors. This is in the context of advanced cancer and palliative care only. And they have looked at RCTs and systematic reviews mostly. So might have missed some of the articles which, looking at one particular symptom alone or some of the article published in languages other than in English. And some evidence from other specialties also used for this review. Not advanced cancer alone. Next one. The practice recommendations are grouped under 4 headings like complications of advanced cancer, symptom control, risk and harms, and quality use of medicines. Now let us examine one by one. Next slide. The practice recommendation in managing complications of advanced cancer, the do's are these. Raised intracranial pressure is a very strong recommendation. But they have also mentioned that higher doses may not have any advantages. They were especially mentioning about studies where no improvement in performance status occurred with higher dose of steroid, but they just added to the toxicity of the steroid, corticosteroids. The same with spinal cord compression. There's no evidence to support higher doses, but it is a do. We can do it. And bowel obstruction, lymphangitis, carcinomatosis, superior vena cava obstruction, and large airway obstruction, they are tentative evidence only. That means there is very limited empirical evidence, but there is consensus among experts and others. Next one. The don'ts, something we shouldn't be doing, is when there is an uncertain diagnosis. especially a lymphoma suspect. The steroids can cause apoptosis of the malignant cells, and this can interfere with the tissue diagnosis of the lesion. Thereby, diagnosis can be delayed and causing more harm to the patient. But this is, of course, if the patient has got a severe morbidity, something like airway obstruction, a life-threatening condition, or when the further investigations are not planned or refused, we can use steroids to reduce the harm in such situations. Next one. Continuing with complications of advanced cancer, the dawn knows that something that we don't know whether steroids, corticosteroids are really helpful or not, or in these conditions. Liver metastasis, obstructive lymphadenopathy, or bronchoria. Next one. Coming to symptom control, the recommendations are the dose that something we should be doing is using corticosteroids for appetite and pain. The evidence are weak. There's weaker evidences, and they recommend short-term corticosteroids, something like a trial. You can give it for a short period, like less than 2 weeks, see the benefit, and if there's no benefit, you can stop it. DON'S are prescribing corticosteroids for vague indication and when we are not able to monitor the outcome. Next one. Non-nos are nausea, vomiting. If a patient is having nausea, vomiting, and this is not non-treatment related nausea and vomiting. Steroids are used to control nausea and vomiting secondary to chemotherapy sometimes, but we are talking about non-treatment related nausea and vomiting. We don't know whether steroids are really helpful or not. Same with mood or fatigue, dyspnea, cough, and most of the evidence of use of steroids for controlling cough comes from non-cancer respiratory diseases like bronchial asthma. And we are not sure whether steroids are of any help to improve the quality of life of people or improve the symptom burden of people who are actively dying. Next one. Now the risks and harms, the do's are duration of use. As far as possible, we should be using it for short term only, like say less than 2 weeks. That is strongly recommended. And if you use it for a longer period, there can be side effects such as these: weight gain, insomnia, intestinal symptoms, weakness, proximal weakness, psychiatric illness, etc. So try limit the use of steroids to the minimum duration of time. Same with doses. Start with the lowest effective dose, and this helps to prevent toxicity. Hyperglycemia, we should look out for hyperglycemia because it can have a rapid onset. Even within 48 hours, the blood glucose level can go up. And this can happen especially with higher doses of steroids. Fungal infection, we should closely monitor for oral candidiasis. It is said that up to 1/3 of people on long-term steroid can develop oral candidiasis, so we should be actively looking for this complication. Gastric protection, yes, you should be using H2 blocker or proton pump inhibitor if you are using steroids for longer periods, say more than 2 weeks. And this is again a tentative recommendation. Other three are strong recommendation, and the recommendation about remains strong means that short-term use, lowest effective dose, and watch out for hyperglycemia. They have got strong recommendation. There's a good quality evidence for that. And fungal infection is moderate, and gastric protection is tentative. That's weaker evidence, but there is consensus among authors and experts. Next one. The downs are prescribing without monitoring. If you are not able to monitor the patient after prescribing steroid, we should be doing it. Similarly, using high doses, more than 12 milligrams of dexamethasone in people with prior neuropsychiatric illnesses. It's well known that steroid can precipitate psychiatric adverse effect, neuropsychiatric adverse effect in people already having neuropsychiatric illnesses, such as anxiety, depression, delirium, sleep disturbances, suicidal ideation. All this can occur in people. So when we have this kind of history in a patient, we should be quite careful about prescribing corticosteroids. Next one. Things we don't know are steroid burst. Sometimes we use steroids in short bursts, like use it for a week or two, stop it, then start again later, hoping that that will reduce the toxicity of the steroid, but we don't know whether that really works. Similarly, in advanced cancer, after stopping the steroids, whether the side effect reverses or patient gets back normal, we don't know. And switching to a less potent steroid, is there an advantage? Like using prednisolone instead of dexamethasone. Prednisolone is 7 times less potent than dexamethasone. So we don't know whether that's of any particular advantage. Similarly, use of calcium or vitamin D or bisphosphonates to counter the change to bone mineral density, to counter the osteoporosis in long-term use of corticosteroids in advanced cancer, we don't know. Bisphosphonates are used in certain conditions, not in cancer, but in some other conditions where people are put on steroids for a long period. But in advanced cancer, there is nothing to suggest that it really helps. Similarly, prophylactic antifungal in advanced cancer, even though 1/3 of people who are on long-term steroids can develop oral candidiasis, it's not recommended. We don't know whether prophylactic antifungals really help in such situation. And same as prophylactic antibiotic to prevent the occurrence of pneumocystis jirovecii infections in advanced cancer. Though it is used in patient receiving steroids for immunosuppression in some other conditions, in advanced cancer, there is no comprehensive evidence to say that its use actually reduce the harm or reduce the side effects of long-term complications of steroid use in advanced cancer. Next one. Now, quality use of medicine. Dose, which they strongly recommend, are patient education and dose once or twice a day. Patient education, yes, and patient should be aware of the fact that they've been on steroid, and they should be able to tell this to another healthcare professional when they subsequently take treatment from some other center, because long-term steroids or high dose of steroid can cause adrenal suppression. So the people who are treating the patient subsequently should be aware of this, and patient also should be aware of this. Dose once or twice a day, mainly because the steroids have a longer duration of action. So divided dose doesn't have much advantages here. Document the reason for prescribing steroids, corticosteroids. Yes, we should always be mentioning why the patient is put on steroids, so that we know whether it's actually working or not, or somebody else looking at the documents should know why the patient is on steroid and whether to continue it or stop, or stop it or not. Monitoring is important. Monitoring for the side effects or the toxicities of steroid, and limit the treatment to less than 14 days if not benefiting. If you're starting patient on steroid and it's not helping him much, then you shouldn't be continuing it. And if you give it for 2 weeks and it's not helping you much, then you shouldn't be continuing it further. Then you should be aware of drug interactions. Mostly hepatic enzymes are involved in the metastasis of steroids. And these have various action on interaction with different drugs. For example, rifampicin can reduce the effect of steroids, whereas erythromycin can potentiate its action. Similarly, NSAIDs and anticoagulants can aggravate the gastrointestinal side effects of corticosteroids. So these are the do's. We should be doing all these things. Next one. And don'ts are something we discussed in the previous slides as well. Don't start with no plans to monitor. It's a strong recommendation. If there's no way we can monitor the outcome or whether the patient is going to benefit or not, don't start it now. And fail to monitor blood glucose level. That's also very strong. And like I said earlier, it can go up within 48 hours. So ideally, after 48 hours, every patient should have a blood check to see whether the hyperglycemia is present. And we should not stop abruptly, especially if the patient is taking 4 milligram dexamethasone or equivalent for more than 5 days. higher dose of corticosteroids or longer use of corticosteroids can cause adrenal suppression, and sudden withdrawal can cause all these symptoms like fatigue, weakness, arthralgia, hypertension, all these things secondary to adrenal suppression. And prescribing corticosteroids without prior assessment of risk is also something we should be doing. Next one. Then the downloads are the corticosteroid of choice. I told you the prednisolone was less potent. It is 1/7 less potent than dexamethasone. So using prednisolone would be of any advantages in preventing toxicity in long-term use, we don't know. And sometimes we prefer dexamethasone for its reduced mineralocorticoid activity, hoping that the salt and water retention will be less. But in the long term, it may not. Long term, if you are using corticosteroid for a longer period, it may not make any difference. Starting dose, what is the best dose to start with in a given situation? Like for example, say raised ICT or spinal cord compression, we don't know. So we advise that we start with a lower effective dose, and higher doses have not got much advantage. Weaning regime, we said that we have to wean the patient off steroids if higher doses or longer steroids are used for longer periods. But how to do it? There's no recommended protocols in advanced cancer. Often it is it's experts' recommendation, like experts decide like how to do it. There are various protocols mentioned in the textbooks, but there is nothing which has got a good evidence in advanced cancer. And the short burst treatment we have already discussed. Sleeping disturbance, we always advise not to give steroids in the evening, thinking that it's going to affect the circadian rhythm of the body. And usually, the steroid secretion naturally, the normal steroid secretion comes down by evening. And if you give an extra dose of steroids in the evening, the sleep can be affected. But there is no evidence to prove that theory. So we don't know. And we generally give it in the morning, and because or in less than 2 doses because of its long duration of action. And whether that's helpful in reducing sleep disturbances, we don't know. And treating steroid-induced hyperglycemia, again, we should treat it, but there's no known protocols. Again, it depends on the expert opinion. Even maybe vary from institution to institution or consultant to consultant on the protocols and approaches. And role of steroids at the end of life, again, we don't know. Sometimes people will continue using steroids, hoping that it will control the symptoms, and also stopping steroids can cause withdrawal. And sometimes people stop it because it is not going to help the patient anyway. So there is no advantage, or it's not advantage of continuing it, and also it might just add to the pill burden, or just we are giving a drug which is not going to help the patient much, so they stop it. So is there any evidence for that of continuing or stopping it? We don't know. So this is a recommendation for quality of medicine. Next one. Thank you very much. These are the steroids. Steroids is a very commonly used medicine in palliative care, and very frequently used, and all of us use it day in and day out. But looking at the indications and what evidence is available for its use in advanced cancer, it was an eye opener for me. And I've changed some of my own practice after going through this article. But the context is only advanced cancer, and in other situations, other conditions, or in early in the course of illness, we don't know how steroids work, and probably we need to. And there is more scope for research and exploring these issues further. Thank you very much.
Thank you, Anil, for that wonderful session. And I thank all the speakers for their brilliant presentations, and which can be easily translated to the day-to-day practice. And if there is any questions from the audience, it can be directed to respective speakers.
If not,
I have a question to Dr. Anil. So it is quite interesting to note that the evidences are not that strong for the use of steroids in the management of breathlessness. And again, the evidence is like tentative, if I recall correctly. Use of gastroprotective agent only when steroids are used only for more than 14 days. And don't know with respect to selection of steroids. I mean, we use steroids second to morphine for the management of breathlessness, except in terminal cases. And also, we often, quite often, most of us prescribe gastroprotective agent for steroids, particularly in the elderly individual. And I think all of us prefer to use dexamethasone considering his long duration of action and less mineralocorticoid activity. So, Anil, could you give some insight into this, whether that was clearly mentioned in the article or?
Thank you, Rajshri. Sorry, I'm not able to switch on my video for some reason.
It's all right.
It is not. So this article is mainly looking at evidence of corticosteroid use in advanced cancer.
Okay.
That is the context, and so we don't know whether in some other situation it would help or not, or we really don't have any idea. So it is for advanced cancer, and something they say that very clear. Like if there is no benefit, we shouldn't be continuing it. And this is something we often forget. Like we just start steroid and forget, reviewing it. And so this was one of those. I mean, some of the strong recommendation that has come from the study, and other things like you mentioned, use of steroids in what was it? I see for a long-term use. You mentioned something
like gastroprotective agent.
Gastric protection, yeah. Gastric protection, yes, if you use it for a longer period of time, yes, we have to. And also, if we are using drugs which can potentiate this gastric side effect, like the anticoagulants or NSAIDs, if you are using it along with steroids, we should put them on gastric protection. But just for a single dose or for a short trial, we probably may not need a gastric protection in such patients. And again, even just out of context, like advanced cancer, there was another study which recently came out. So, it's about overuse of PPIs in many situations. So the recommendation was to use minimum duration of time, also for PPIs, and only if it is absolutely indicated. That's another thing out of context. But the confusing thing about steroids is that if you want to stop it, how to stop it? There is no given protocol on weaning steroids.
Exactly.
Different textbooks give different things, and one, I think the palliative care formulary, which suggests two methods: one to reduce it by half, and then slowly every week reduce it by 1 to 2 milligram of dexamethasone equivalents, or to bring it down to physiological steroid levels, like it will be around 7.5 milligram of prednisolone or 1 milligram of dexamethasone, then slowly reduce it over next 3 weeks. So in advanced cancer, whether that will be useful or not, I'm not very sure, because if the patient is very in advanced situation, many of us have stopped using steroid altogether, hoping that is going to cause more harm to the patient than any benefit. Yeah,
it's very important that we need to clearly document why steroids are started for, and what are our plans for, whether stopping or weaning, and are we really monitoring the side effects? In a multi-specialty hospital, when steroids are started from other specialties, I'm not sure whether these things are properly documented. In palliative care, we usually do, but this is quite interesting to find out the points, very valid points. And there is one question to Dr. Naveen, I think. I think that's from Farsana. Would you like to take it on, Farsana? Like I wonder how could we implement theory of change without help of external grants in our part of world?
Yes, thank
Yes.
you, Radheshwar. Actually, it was really wonderful to listen to Dr. Naveen. And we know that theory of change works. But most of the time, what we see that we do theory of change, any of the theory of change work with the help of any external grant. But later, we don't replicate all those things. So what could be our approach from, our part of the world? So how could we do that without any external grant or donation? Thank you.
So, firstly, the grant was written for conducting physical workshops, and the facilitators were supposed to fly in from UK and conduct this. So due to COVID, nothing happened. So no facilitators could fly in, no physical workshop happened. So grant money was not used, although we had a grant. So everything was conducted virtually. Basically, you need a good mentorship to conduct these stakeholder workshops and follow up a meeting. It's a lot of intense work that goes in planning and conducting the workshop and implementing it in your practice area. So I would not think that finances are the major or the critical barriers for conducting this, but I would feel that the motivated stakeholders and excellent mentoring, I think this combination is what would bring that change.
Yes, Naveen, I would like to have a question. Like when these workshops are conducted, who were the people attended the workshop? It was only, from the Manipal side?
No. We selected 5 intensive care units across India. And there were intensivists from them. And because, finally, they are the primary stakeholders, isn't it?
Okay.
Although we want this change to bring about, they are the primary stakeholders. So we try to bring their perceptions for each of from the final impact to long-term outcome to preconditions to assumptions and everything, including planning. And they were the major stakeholders that were there. So basically, we wanted to develop this theory of change as a framework for one context and to see whether this could be replicable and scalable. That's what our intention was. So if we want to develop this into a vertical of palliative care in the future, we need strong evidence coming from India. So this is very preliminary work, I would say, or a very beginning work that what we are doing.
Can I ask you how much time it took from the virtual workshop to actual implementation?
So a lot of things were happening simultaneously. Before even the workshop began, we had this relationship. But I think over a period of 6 months, I think these workshops and several planning meetings between the workshop, between the facilitators, I think it was in probably a 6-month effort.
Okay. Thank you, Naveen. There is one more question to Dr. Anil Paleri. Is there any evidence on the frequency of steroid administration and when it should be given? Means like we avoid using them later in the evening. I think you have explained that, but would you like to clarify once more?
There's no evidence. The thought, comes from the fact that in circadian rhythm, like normal body, the steroid secretion will come down in the evening, and it usually starts in the morning. So the theory that suggests that if you give a dose of steroid in the evening, that will reduce the steroid level within the body and can affect the circadian rhythm, thereby affecting the sleep. And what they say that there's no evidence for that, especially in advanced cancer. So, and again, I think if you look at the duration of action of steroids, dexamethasone got almost like more than 24 hours duration of action. So whatever advantage you have in giving in a single day dose or twice a day dose will be lost by the second day or third day, because a drug with such a long duration of action will be obviously will be accumulating within inside our body. So for the disturbance in sleep, there's no evidence. So it's more, remains like a theoretical thought than something with actual evidence.
Correct. There is one more question. What about the steroids, use of steroids in lymphangitis carcinomatosis? I think you have mentioned that there is a strong evidence.
Yeah, there is anything which increases the intracranial tension. You can use steroids.
This is about lymphangitis carcinomatosis.
Lymphangitis carcinomatosis, sorry. Yeah. There's a tentative evidence.
Okay.
There's not nothing to suggest a strong evidence.
Okay.
The strong evidence are for raised ICT and spinal cord compression. Even there's an advantage for higher dosage. Doses more than 16 milligram doesn't give any advantage over smaller doses.
Okay.
With it add to the toxicity. So nothing to prove that in a higher dose like 36 milligram or 48 milligrams have any advantage in raised ICT also. Yeah.
That's also interesting because lymphangitis carcinomatosis without steroids will help a lot. Okay. Any questions pending?
Yeah. Are there any more questions from the audience? Actually,
We overshot
we
the
have
time.
exceeded the time. Yeah, we have exceeded the time. And thank you very much, all the chairpersons, speakers, everybody, and all the audience who have been patient on a Saturday night to attend this session. Thank you very much, everyone.
Thank you.
Naveen,
Thanks
thank
to
you,
the moderator and the
Thank you,
speakers.
Rajeshri.
Bye.
Pranit.
Thank you. Bye.
Thank you very much, madam. Thank you for the